Thank you so much. Okay, let's have, do you want to do questions first? We'll do, I know we need to do that. We'll do 10 minutes of questions and then okay. So our speakers, Charlotte, would you mind having a seat? Katie and Carol coming back. And if you have questions, one second. Go ahead and pass those to the end. We'll just take a few minutes for questions if there are any. And then we're going to have lunch. All right. Yeah, just 3 of you. All right, Dr. Williams. This is lichen sclerosis questions. Laser therapy, does this look promising as a treatment? And that's the first part of that. And then if applying steroid ointment, do you use barrier creams between steroid ointment applications?
So I think the laser therapy question is not the ablative laser that I was talking about for treatment of different types of lesions, like in the OR. This laser therapy is surface, like resurfacing. Right now, it's in the context more of cosmetic uses. There haven't been any official studies on lichen sclerosis per se. There's a few studies on menopausal patients and quality of skin and different symptoms of atrophy. Is it promising? I may or may not have heard stories about patients with good results in lichen sclerosis, but I don't think I'd be confident in recommending that as an option right now. For the other question, using the barrier creams, yeah, so that's why I use the steroid ointments at night. During the day, like first thing when they get up, that's what I recommend, to use a barrier cream and reapply during the day as needed, but get really clean skin at night before putting in the ointment.
All right, Dr. Pennington, circulating tumor testing. The question is about whether this is a clinician tool or a patient, or should we look at it from a more patient-centric, how am I doing approach? I'm not sure what maybe just what are your comments on that?
I mean, I think it's
dichotomy?
both. I think we all, both doctors and patients, want to know how you're doing. And this could be one measure when you're on a treatment. Do we see that circulating tumor DNA going up or going down? But again, I just think we don't know a lot yet about how to use it in actual practice. But I guess I would say it's patient-centric in that way, that we all want to know. But I also think we have to be careful to be doing a really good job of explaining to our patients what it can and can't do, right? Because you don't always have all of the information about how to interpret it. And so to make it truly patient-centered, we need to make sure that we're sharing that information about what it means.
And what we don't know it means.
Yeah.
Yeah. Any other questions that before we?
Yes, Charlotte. I think of how those decisions might impact the patient, but I wonder from a doctor's perspective, can you speak to that?
Sure. Sure. I think I tried to be illustrative in the 3 examples that I gave, right? I think the first scenario where the woman has decided what she wants to do and is just, checking in with you to see if you're on board, that is the easiest one. The second scenario where the patient and family feel that you're not doing enough is the hardest one. Well, probably not the hardest. I would say earlier in my career, that was the hardest one because, we are in the struggle with you. And I think that was probably the hardest one. Now, I would say the hardest one is, again, when you know that what you're doing, particularly a chemotherapy drug, is not going to extend someone's life. but you're the person who still has to administer that drug and treat the patient. And so that may be aligned with some of our core values as physicians, right, in terms of harm and really balancing that, but it's not always our decision. And a lot of times it should not be our decision. We do our best. But overall, each time, it's not easy.
A good question.
Yeah, I think anybody. else
Anyone could answer that.
comment
Yeah.
on-
All right. Any other questions for us? Yeah. The question is if there's a discrepancy between what a patient wants and what possibly evidence would suggest, do you ever involve ethics?
Yes, absolutely. And so to bring up the second scenario again, where the patient ended up leaving our facility, I did request an ethics consult just to review her case, and not only an ethics consult, but just to really recruit as many people in the hospital as possible to communicate with the family. So I don't have, you should never be worried about getting a second opinion or a third opinion or a different opinion. So by involving ethics, medical oncology, palliative care, because sometimes we just need to hear the same information over and over again before we can accept it. But yes, an ethics consult can be helpful from that regard. But rare, I would say I do that rarely.
Okay, last call for questions. Yeah. Sure.
That previous over. Is there any research being done about proton radiation? Is that in any way beneficial in some way to traditional radiation therapy?
Not aware of that at all. If anybody else is, please chime in.
I'll add something to that too. So proton therapy is a way of giving very focal radiation, whereas when we give regular radiation, it's usually broader, although to different degrees. Often if we're giving radiation for a vulvar cancer, it's because we need to cover a wide area. So often proton therapy isn't quite what we need to do. So that also may be why there isn't as much studies about it. But not that I'm aware of. I don't.
Well, the protons, I don't know the complete physics of it, are designed to go deeper, right, than our other type of radiation therapy, which is usually electron-based. So it covers more surface areas like the vulva than proton therapy, which, targets a lesion that's deeper on the surface of the skin. So it has not been shown to work as well.
All right. Thank you, three.